remembered that without even looking at the slides, right? Everybody remembered that, because that was the one thing I said, no matter what happens, I want you to understand that diabetes is not a sugar problem, it is an insulin problem. So if I don't have diabetes, I can eat a whole cheesecake and my body will make as much insulin as I need to take care of it, and I move on with my life. But if I have diabetes and I try to eat that whole cheesecake, it's not making any insulin or it's not making enough insulin, so I end up having too much sugar in my blood, right? And the longer I have that, then I have all the complications of diabetes. So diabetes is technically, the problem is not with the amount of sugar that you consume, it's with your body's response to the amount of sugar that you consume. Everybody remembers that, right? Okay. So insulin. The reason insulin is what we're looking at is that it's the hormone that lowers glucose in your blood. So when you consume that whole cheesecake, that insulin is what lowers the glucose in your blood, right? Glucagon is the opposite of insulin, right? And I think I asked you a couple questions from this slide on the game that we played. But glucagon is the hormone that is released from pancreatic alpha cells. Anybody know where insulin is released from? The pancreas, right? Pancreas. So the pancreatic beta cells release insulin, the pancreatic alpha cells release glucagon. Glucagon works opposite of insulin by increasing glucose in your blood. Everybody okay with those concepts? We have to understand those concepts for the rest of it to make sense. Everybody's good? All right. Type 1 diabetes. So with type 1 diabetes, beta cells, remember I said in the pancreas, the beta cells make insulin. So with type 1 diabetes, those beta cells are destroyed in the pancreas for whatever reason. We don't know why. It's technically autoimmune. The body just decides to destroy those beta cells. Okay. Once those beta cells are destroyed, insulin can no longer be produced because that's what produces the insulin. It destroys all of them. It doesn't destroy some and leave some. It destroys all of them. There are genetic components to type 1 diabetes. We don't have real reasons why it happens, but there are genes that are associated with type 1 diabetes. Type 1 used to be known as insulin-dependent diabetes or juvenile onset diabetes, but we're seeing type 1 more and more in older people, and we're seeing type 2 more and more in younger people. So we remove sort of the age association with it. But traditionally, type 1 presents in elementary school age kids. Okay, so insulin, why do we care? We need it for survival, like I explained. It helps us get rid of the sugar or the glucose or the carbohydrates that we've consumed. And without that insulin, glucose cannot enter the muscles, cells, and then fat starts being used as an alternative energy source, which some people like a little bit because it helps with weight loss. That's why there's the keto diet, when you don't eat any sugars and you're just eating fat, so your body has no choice but to burn the fat in your body. But at some point you're going to need sugars, so eventually that diet doesn't work. But sometimes people get happy trying it for a little bit. Yeah. All right. So type 1 diabetes, not as common. It accounts for about 5% of people with diabetes. A lot of them, because they are required to have insulin, a lot of them actually use an insulin pump. And it's programmed and it auto checks how much insulin they need, especially because a lot of them are children. When they first get diagnosed, they just kind of start off with a pump and remain with a pump because they're not used to just being able to continue to live, and the pump does what it needs to do by trying to mimic what the pancreas does. All right. The onset is usually rapid. Is it warm?
Yeah, it is.
Just take your mask off.
Yeah.
I mean, HISD doesn't move. And I'm 6 feet away from Jimmy Alvin. I'm sorry, it's so hot under that mask. Dr. Capers, don't tell anybody, are you in the class? You don't see me.
Don't find out. That's our CPR skill.
Okay, main rep, I'm kidding. Main rep, okay, so the. Are y'all certified yet?
What they say now? This is
Alright, so the main risk factor for type 1 is family history. Presents usually as DKA. I think Dr. Wang comes in and does a whole lecture on DKA for you guys, or somebody does. But very quickly, diabetic ketoacidosis or DKA is where there's no insulin, and it leads to the conversion of fat to ketones for energy, but the ketones are acidic. So you eventually get too high of your ketone levels, and you go into what we call diabetic ketoacidosis, which is very dangerous. Okay. There is a test to determine if a patient has type 1 diabetes. So back in the day, you would just kind of diagnose based on all the symptoms, right? It's a child, they present with super high blood glucose levels, etc. But there is now something called a C-peptide test, and that C-peptide test checks to see whether there are any beta cells left, what your beta cell function is, whether you're still able to make insulin, and then you can sort of definitively diagnose with type 1 diabetes. Type 2, this is where we're going to focus most of our effort. We're going to learn everything there is to learn about insulin so you understand how to treat type 1. But type 2, okay, let me put this back on because now I have to cough and
yeah, keep the cops.
So 90 to 95% of diabetes mellitus is thank you very much. That's why I brag about you. Okay. I do brag about you guys. So there are 2 reasons why you'll see type 2 diabetes. And I know we talked about this last year, but let's just pretend, right? So 2 reasons. There will be insulin resistance, which means your body is not using the insulin as well, right? So you have insulin, but your body, for whatever reason, is not using it as well as it should. So there's decreased sensitivity to the insulin that your body is making. And then there is decreased pancreatic insulin output, so you're just not making as much insulin. And here it's usually because there is just a decline of beta cells. Most people throughout your life, you will lose beta cells, but people with diabetes lose them faster and lose them at a more steep level. So as that continues to go down, your diabetes continues to worsen, okay? So decreased insulin sensitivity and insulin deficiency. So all the medications that treat type 2 diabetes will work on a couple of these things. They will either help increase your body's sensitivity or your body's ability to use the insulin that your body is making, or they will help you secrete more insulin. They'll help you make more insulin. So your mechanism of action, anytime you sort of get confused with your mechanism of action of your drugs, sort of come back to that second bullet, right? Most of your diabetes drugs need to be either increasing the sensitivity of your body to the insulin that your body is making or helping you make more insulin, okay? Other drugs will also help you like eat less, that kind of thing. But for the, the core mechanism of action is going to be as a result of increasing sensitivity or helping you make more insulin, all right? If you can grasp that, that will really help. I know you guys are going to have PODA in the morning where they'll talk to you about this. Like if you can just highlight this, write it out somewhere so that as they're going through those drugs with you, you're trying to make this connection yourself, okay? So type 2 diabetes is usually slower onset versus type 1 diabetes that just kind of happens all of a sudden. Type 2 diabetes is progressive. So even after you get diagnosed with type 2 diabetes, over the years, you will eventually make less insulin. So it does get progressively worse. And this is something that we sort of have to work on with our language when we're talking to people with diabetes. Because a lot of times we threaten them with insulin, like if you don't do X, Y, and Z, you'll end up on insulin, but most of them will end up on insulin anyway. So we need to sort of be careful with our language there because their beta cells will continue to decline the longer they live, period. So if they have type 2 diabetes, chances are eventually they're gonna end up on insulin. So we wanna be careful not to use insulin as a threat when we are counseling our patients. All right, type 2 diabetes is strongly associated with obesity, physical inactivity, family history, and the presence of some comorbid conditions. I know this is not as easy to see, but you can sort of see the pictures. So I know that we can sort of work with it. You can't see my mouse. Okay. All right, so this is another picture that I really like because it explains a lot of the different places where the drugs work and how those drugs work with diabetes. So some drugs will work on the brain by telling the brain that you're full and you don't need more food. And if you consume less food, then you have less glucose that your body has to get rid of, okay? All right, and then the liver. With the liver, it can increase gluconeogenesis. And anytime you see any of these words, don't let it confuse you, don't let it, scare you. You know what gluco is, right? That's the sugar. You know what neo is, that's new, right? And you know what genesis is, that's creation. Anytime you see any of these words, don't trip up on it. Don't start wondering, what that has to do with anything. Just break it down that way, and you'll be able to keep going forward, right? Does that help? Yes? You'll need this tomorrow, for sure, when we are talking to you in PODA, because then you'll start looking like you don't know, but you do know, okay? All right, so the liver increases gluconeogenesis. So you'll find some drugs that work on decreasing gluconeogenesis. So you'll know that those drugs work in the liver. And then the pancreas is where insulin is made. So we can work on decreasing or increasing insulin secretion here. So you'll find some drugs that work by increasing insulin secretion or decreasing glucagon secretion. And then we also have some drugs that work on the intestine. So they work on decreasing the absorption of whatever it is you have consumed that will increase your glucose. Okay, everybody with me so far?
I'm sort of confused because that one you said decrease, but in the pancreas you're saying increase, but the arrow's pointing down. So what is that?
So sorry, this is what happens in hyperglycemia.
Okay.
So when a drug is working, the drug
Does
is
the
working
opposite.
to do the opposite.
Okay.
Yes. Everybody okay with that? For instance, like with the liver causes, or with hyperglycemia, you're seeing increased new glucose being made in the liver, right? So any drugs that you see should be decreasing gluconeogenesis. With the pancreas is decreasing insulin secretion and increasing glucagon. So we want our drugs to do the opposite. Okay. And then with the intestines, there's something called GLP-1, and that works with helping reabsorb the glucose that we've consumed in our diet in the intestines. So we want more of GLP-1. And then in the muscle, with hyperglycemia, we see decreased glucose uptake, but we actually want more glucose uptake because that helps us burn the glucose, okay? And then your fatty cells, or your fat cells, there's an increase in FFA, or free fatty acids. So we want drugs that are able to help us reduce that. There's also an increase in adenopollectin, which is just a type of fatty acid. So we want to see sort of an increase in that. I don't think we actually have drugs that work on this piece, but there is some questions about the role of inflammatory cytokines. But we know that that contributes to hyperglycemia. And then the kidney also increases gluconeogenesis and increases glucose reabsorption. All right, so whenever you are looking at a diabetes drug, it should work in one of these places. Okay? What we'll do is we'll talk about this slide again tomorrow after you guys have had CODA, and you can ask me whatever questions you have after you've seen the drugs. Okay? Other types of diabetes, gestational diabetes. That's exactly how I looked when I was pregnant. I was super cute. Nobody looks like that when they're pregnant. I mean, like 2 people, but the rest of us. Her nose didn't, okay, we're not moving on. So in pregnancy, there's glucose intolerance that occurs. Your body just pauses and says, I'm gonna grow this baby. When I'm done, I'll come back to you. So it literally just happens when you're pregnant. Now it puts you at increased risk for having type 2 diabetes later in life, but usually you just have the diabetes when you're pregnant. So that's why we call it gestational diabetes. Your body says, I'm gonna pause, you'll be fine, I'll be back. Let me grow this child, when I'm done, I'll come back and take care of you. But it does put you at increased risk for both obesity and diabetes later in life. And it can also cause fetal macrosomia, which means a big baby. The oral glucose tolerance test, that's what OGTT stands for. You guys know how I like to throw that in, because that way if you're not in class and you don't know what it means, I mean, I guess you could Google it, but I like to put things in there that you don't know so that you can want to be in class. So the oral glucose tolerance test is preferred for testing, usually between week 24 and 28 of gestation. And if you've had a baby before, they give you this nasty pink liquid that's very thick, and you're already nauseous, but you have to drink it, and then you have to sit there for like an hour, and then they test your blood glucose and decide whether or not you have gestational diabetes. So, and if you have not had a baby before, you can look forward to that. All right, pre-diabetes. So pre-diabetes just means that you're at higher risk for developing type 2 diabetes later in life. Your blood glucose is high-ish, right? It's not high enough for a diabetes diagnosis, but we kind of see that you're trending that way. You kind of see that your beta cells are depleting. It's generally defined as an A1C greater than or equal to 5.7. Metformin can be used to delay diabetes onset. So if you notice that you have it, even though you don't have diabetes, you can be prescribed metformin right away. Other ways that it can be diagnosed is if you have impaired fasting glucose or impaired glucose tolerance. So what are some hallmark signs? This was one of the questions that I asked in the bucket. Of hyperglycemia. What are classic symptoms of hyperglycemia? This is one of those things I told you that if I wake you up in the middle of the night, you need to be able to answer polyuria, polydipsia, polyphagia, right? Patient presents with frequent urination, frequent thirst, frequent hunger. Those are considered classic symptoms of type 2 diabetes. There are other symptoms, and not everybody presents with the classic symptoms. So blurry vision, fatigue, weight loss, dry skin, poor wound healing, recurrent infections are all other symptoms that you may have. When my dad was diagnosed, he just had the blurry vision. He was not overweight, he didn't have any of the other things, he just had blurry vision. He kept going to a bunch of eye specialists and they couldn't figure out what was wrong until somebody mentioned, let's check your blood sugar. But because he wasn't obese, I think he was like 40, they weren't suspecting diabetes. But somebody eventually tested his blood glucose, and once he got his blood sugar under control, the blurry vision went away. So, there are other ways it can be presented. Alright, so as pharmacists, and you can go ahead and start this slide, because I will almost always ask the question from here. Because as pharmacists, when somebody who we don't expect to have diabetes presents, sometimes it could be from a secondary cause. There could be something else going on that is causing it. Now, we may not always be able to fix it, like if a patient is on an immunosuppressant, well, they're gonna stay on their immunosuppressant, right? But at least we know that there might be something else that's leading up to it or that's causing it. So, I'm not gonna go through the list, but some very notable ones. Second generation atypical antipsychotics are very notorious for causing diabetes or leading to diabetes. Some believe that patients were going to get diabetes anyway, but there is a very strong association between the atypical antipsychotics and diabetes. And I know that you guys have already had neuro, so I hope that you learned that when you learn neuro, but something else to keep in mind is that these drugs are not only used as antipsychotics anymore. A lot of them are used as antidepressants as well, to augment the therapy. So back in the day, we would always sort of know that our patients who have schizophrenia or bipolar, that, you know, this is something that we're watching for, but now that these drugs are being used in a much wider population, it's definitely something that we should all keep in mind. Statins, I think I taught you guys about this, right? Did I? 2 weeks ago, 3 weeks ago, when we had, okay. So statins are also associated with an increased risk for diabetes. We still keep them on the statin, we just figure out how to manage their diabetes. One other thing would be infections. So when you have an infection, this is another time that sometimes the body will say, there's a bigger problem at hand, I'm gonna stop and take care of this and I'll be back. But this can be very problematic for patients who have type 2 diabetes. If they already have type 2 diabetes and they have an infection, they have such a hard time keeping their blood sugar under control while they have that infection because their body is focused on something else. So I will almost always ask a question from here because this is something that I want you to always remember. Protease inhibitors, so our patients that are living with HIV/AIDS, this can also be a problem with them. You are going to see patients on beta blockers and thiazide diuretics that have diabetes. It's one of those things where if they already have diabetes, we might think twice about putting them on it. It's not contraindicated. But if they have diabetes, or if they have already been on it and they have diabetes, we treat the diabetes. We don't necessarily need to switch. But if we notice that they are just having a hard time getting their blood glucose under control, then it might be something to consider to be able to help them. But it's not contraindicated in patients with diabetes. Any questions on this slide? Alright, so why do we care? What's the problem with hyperglycemia? Eventually, just continue to live with high blood glucose, you'll end up with macrovascular complications like coronary artery disease, peripheral artery disease, or stroke, and also microvascular complications. So patients with diabetes might end up with nephropathy. Yes, sir.
Yeah, regards to the follow-up of all. So, in terms of the last bullet there, we now stop whatever medication we are using for the hyperglycemia and look and take care of the infection first. Is that what you mean?
No, so I understand your question. When a patient has an infection, usually if they have diabetes, they have a very hard time controlling their blood sugar when they also have an infection, which, depending on the severity of the infection, if they're hospitalized, can complicate their course, right? Because now we are not only trying to treat the infection, we're trying to make sure that their blood sugars are back under control. So There's nothing you can do other than be vigilant and understand why their blood sugars are sort of under control or out of control. If there's somebody who's already on insulin, you may need to dial up their units while they're hospitalized, or even while they're at home, even if they're not admitted. They may need to be on a sliding scale insulin. Do you guys remember what a sliding scale insulin is? No, I don't think I taught you that. I did not. Exactly. So that's when we sort of adjust how much insulin they get based on what their blood glucose is doing. So let's say that they normally get 5 units of insulin at bedtime. Well, maybe if they're going through something like they have an infection at the time and they're having a hard time getting their blood sugar under control, we might say, okay, if at bedtime you test and your blood glucose is between 150 and 180, do 10 units. If it's between 180 and 220, do 15 units. So the scale, how much insulin you get, varies based on what your blood glucose is in that moment. So that's a sliding scale. So when they have something like an infection that they're having a hard time controlling, we generally use a sliding scale sort of to be able to help keep them under control until the infection is gone, and hopefully they'll regain control and they can go back to whatever their dose was before the infection. JD, did you have a question?
I was just asking, like, if that's the approach for any like acute condition if someone has diabetes and has hyperglycemia, you know?
The sliding scale thing?
Yeah, like that's the approach to if they're having anything, you know.
Sliding scales can be used a lot, right? That's just one example of when you would see a sliding scale, but a lot of times in the hospital, it's a sliding scale. We try not to send patients home on a sliding scale because it can get confusing. But if it's a patient that you know can handle it and needs it, you can give them a sliding scale to use at home, but sometimes it's just trying to establish a dose, right? We just don't know where this patient is going to land. We're starting insulin for the first time, so okay, do this. If it doesn't work, then let's increase it, let's decrease it. A lot of times, clinical pharmacists will call the patient and say, what was your blood sugar this morning? Okay, this is what I want you to do. If it's a patient that we're not sure will be able to handle doing the sliding scale themselves. So you will encounter sliding scales, and some of you who work have dispensed a sliding scale. Like you've had to type up a complicated label where you know?
Yes.
Okay, a couple people. All right. So that's a sliding scale. Write that down. I may ask a question about that. I think that's important.
Would it be like a case scenario whereby we have to know how much to give them based on the sliding scale? Or just know what it is?
Scale, and everybody really likes for it to be like a nice formula. It's not.
Oh.
It's not. It varies. It depends on what the patient is already doing, has done before, has tried, what has worked, what hasn't worked.
Mm-hmm.
There's no standard. I mean, a lot of hospitals have like a standard, but they adjust it very freely as needed. Good. Okay. It's hot. What time is it? Are we done yet? No.
Bless you.
Fine, I'll put it back on. That's what she was saying with that speech. Okay. Alright. I'm kidding. They do things that you guys know that Fauci said that we should expect another spike in COVID, right?
Is that what we got the machine?
He did what?
Is that what we got the machine?
Wait, we have a machine?
Yeah.
It's just sitting outside?
Yes, ma'am.
Oh, yeah. I didn't know. Is it the air thing? Is it the air you're supposed to sanitize?
When you walk through.
Yeah, they walk through, it's supposed to scan. It doesn't work.
Okay. Going before and after class. Okay. Nephropathy. Alright, this is, again, I think this is one of the questions I asked you guys, but I really want you to be able to think nephro, kidney, whether or not you actually remember, neuro, brain, right? So I want you to always sort of try to break it down, retina, retinopathy.
Alright.
So microvascular complications, the way I think of this, and it's not very scientific, so let's pretend Dr. Capers is not in the room, but I think of like tiny vessels, right? And I think, the vessels that supply blood to your eyes are tinier, right, than some of the macrovascular, because when you think of the heart, it has like tubes in it, right? Versus, super tiny vessels that are leading to your kidneys or to your periphery or to your eyes. Again, very unscientific, and don't tell anybody I taught you this, but I think of like the peripheral arterial disease or those really the microvascular complications. I think of when I spill a Coke, it's super sticky, it doesn't move as quickly, versus when I spill water, the water is able to sort of, and then I clean it up and it just cleans up nice and easy. That sounded like somebody's car just felt like a branch on it. It's fine, hopefully. It's not any of our cars. Or somebody who really hates their car. That's good. So with the microvascular complications, I think of it as like hyperglycemia, like a Coke is running through your veins versus water running through your veins, right? So the Coke is not able to move as easily, so you don't get the oxygen to all the parts that you need the oxygen to get to, and those parts start dying off. If that doesn't help you, put it in the trash, but if it does, right, it's easy, like when a Coke spills, it's just sticky, it's not moving as easily versus if you spill water. So think of your normal glycemic body as water, and then think of the hyperglycemic one as a Coke, trying to make its way through all those super tiny veins. It's just not able to do it as quickly, so we have those complications like blindness, kidney disease. So a lot, I think, can't remember what the percentage is, but most people on dialysis have both hypertension and diabetes, right? And then the neuropathy is the nerves. Have you ever watched somebody that has diabetes try to do a finger stick? They're just like, I don't know, what if it doesn't it? They don't feel it anymore. And it's not because they've poked it so many times, it's just because the nerves there are not as alive as they used to be. And that's also what leads to amputations. They start losing feelings in their extremities, in their feet. They step on a nail, they don't know they stepped on a nail, foot gets infected. By the time they realize what's going on, they try to treat it, usually with IV antibiotics, but those IV antibiotics can't get all the way there because those nerves have died and we don't have enough blood flow to those areas. So we're not able to actually, treat it. At this point, trying to treat it topically, you can't get to the infection that way, and the IV antibiotics can't get to it either, so we end up having to start amputating. Okay?
The amputations for like diabetics, does that come with infections, or does that come when the blood is so syrupy, the limbs can't get enough oxygen it needs to go?
Both.
Both.
So sometimes it's just we're not able to get enough blood flow, and there is like skin necrosis, so it starts dying. But a lot of other times it's infected as well, and we can't treat the infection, so we amputate it so that the infection doesn't continue to spread. And sometimes you'll have multiple amputations, like you might start with toes, and then go, and it just keeps going up.
Would you say that happens to people who are not adherent to the therapies, or is just something that eventually happens as you progress through the disease?
So that's a good question, and I don't know that I know the answer. I know that there is a higher incidence of amputation in African Americans. So I don't know if there's a genetic component. I know that not everybody who has diabetes has those complications, or not everybody has it to that level of the skin necrosis. But a lot of it is also just taking care of your feet, like foot care for diabetes. That's on one of the later slides, is very important. They need to look under their feet every day. They need to make sure that they don't have cracks in their skin, because the necrosis starts there. They need to make sure they haven't stepped on something and didn't realize it. So there are ways to help prevent it, but there is definitely a disproportionate amount of African Americans men who end up with amputations than everybody else.
So are there any mechanical support that can help increase blood flow in that area?
They can wear the
Maybe the
The
socks.
skin is tight, compression.
the compression stockings. So there are a couple of little things that can be done, but for the most part, it's making sure that you're looking under your feet every day. But the older you get, the more difficult it is for you to be able to, right now, I shouldn't have even done that, because now my legs
But
are
you know,
hurt.
like, and for heart failure, they use stents and things like that. How come there's nothing down there that can use to increase the
It's the
blood flow?
blood. The thing about from the blood is that the blood is served. Like
Oh.
if you turn it upside down, it will just like still when it gets to your head.
Oh,
It
so it's
water,
not plaque related,
blood
it's
straight
more
through
so blood
it. It is so
viscosity.
thick it can't get to the limbs no matter what.
I used Coke, but Jamie used molasses.
Yeah, that's mine.
Okay,
But it
okay.
works, but it works.
Yes, sir.
I see, okay.
Yeah.
So it's not like a plaque problem, it's more so blood viscosity type of
It's
problem.
just those nerves are so tiny,
Oh,
right? They're so tiny. You can do like a stent in a heart because we're talking arteries,
this,
right?
okay.
But when you're like in those super tiny, it gets really complicated. And then once it dies, it's dead. You
Oh.
can't revive a nerve. Like,
You know about drawing a needle, like when the stuff is too thick,
Mhm.
like
You can't go, okay. I see it.
I like it. Okay. How do you guys feel? Do you feel like you know diabetes? Nope.
How we feel about them?
Not today. I'll ask you tomorrow.
Yes.
Alright. Let's make a comment. What time does this class is it supposed to end? 2:50. We'll be done at 2:30.
Yay.
Okay. But I'll talk fast.
That's
What
fine.
we have tomorrow to make sure. Alright. Criteria for diabetes diagnosis. Please don't miss this. Please don't mix it up with the goal of therapy. This is for diagnoses. So to diagnose, A1C has to be greater than or equal to 6.5%. That's the standard. That's how diabetes is diagnosed. Everything else is used, but not really for diagnosis. But when a patient comes in, what we normally would do is a Chem 7, right? You guys know what a Chem 7 is with the
BNP.
stick figure or whatever?
Yeah.
Yes. And that includes a fasting glucose. So that generally tells us there's a problem and then we need to follow up, right? But in general, if we're looking to diagnose diabetes, we're looking for A1C. But you're going to see so many other Chem 7s that you need to know when it's out of whack. So fasting plasma glucose greater than or equal to 126. Fasting means no caloric intake for at least 8 hours. Or a 2-hour plasma glucose that's greater than 200 during an oral glucose tolerance test, and that 75 grams of anhydrous glucose dissolved in water. So that's that orange syrupy thing I told you that pregnant women have to take.
Mm-hmm.
So that's how you would do an oral glucose tolerance test. If the patient already has symptoms of hyperglycemia, they come in, they tell you that they're having the polyuria, polydipsia, polyphagia. When we do one test, we kind of believe them, right? But in general, we want a couple tests to be able to verify if we're not using A1C. But other than that, we generally try to do at least 2 tests. What are some risk factors? I kind of already touched on this, but physical activity. If you have a first-degree relative with diabetes, if you're a high-risk race is anybody who is not Caucasian. For diabetes, that is. If you're a woman who has delivered a baby that weighed greater than 9 pounds, or if you were diagnosed with gestational diabetes while you were pregnant, if you're overweight, and unfortunately for my Asian American friends, your definition of overweight is a little stricter than the rest of us, so it's 23. Yes. Don't ask me why, I don't know, I didn't make the rules. Hypertension, if you have hypertension, you're higher risk for type 2 diabetes. If your LDL is low, if your HDL is low, so if your HDL is less than 35, or if your triglycerides are greater than 250, If you're a woman who has polycystic ovarian syndrome, that is an indication of insulin resistance or your body not being able to use the insulin as well. So that's a risk factor. If your A1C is greater than or equal to 5.7, if you have impaired glucose tolerance or impaired fasting glucose, if you have a history of cardiovascular disease, that tells us that there might be some insulin resistance going on, and then severe obesity as well. Okay, so those are risk factors for type 2 diabetes. Goals of treatment. A1C less than 7. This is one of those things that you need to know in your sleep, right? A1C less than 7 is our goal for treatment. Preprandial plasma glucose should be between 80 and 130. And that's very important because patients will call you all the time and say, I just checked my glucose, what is it supposed to be? Is that high? Is that good? Is this a good number? So you do need to know that number. So preprandial, before they eat. Fasting is another word for that, between 80 and 130. Postprandial, less than 180. Okay, so those are the patient's goals.
Is this the box where we know if the glucose is impaired?
This is a patient already has diabetes, and they are, if they go for their lab work, we want their A1C to be less than 7. If they happen to be doing a self-monitored blood glucose, or if they happen to come into the clinic and you check their fasting glucose, or they've already eaten but you check it anyway, we want it to be less than 180. That needs to be at least an hour after they've eaten. So postprandial, we say 1 to 2 hours after you've eaten, or preprandial should be fasting, so at least 8 hours since you last ate something. When we check that, we want it to be between 80 and 130. Now, back in my day when I went to pharmacy school, that number was between 70 and 120. But we were having too much hypoglycemia, so they shifted it a little bit. Because hypoglycemia can turn back quicker than hyperglycemia. Hyperglycemia takes time, right? It's having hyperglycemia over a long period of time that you end up with those micro and macrovascular complications, okay? But hypoglycemia can have an immediate effect where you can actually pass out because you don't have enough glucose in your body. So the reason, we don't just go lower everybody's blood glucose real quick is because we need to balance that. We need to you still need the glucose in your system to survive. So that's sort of a happy range where we want you to be, where we know that you won't be at risk for severe hypoglycemia. Now, if somebody has a shorter life expectancy, or if they have a history of just suffering from hypoglycemia, we may need to adjust to those numbers a little bit. Okay, so if you, for instance, you have a patient that has cancer, the diabetes is probably not going to get them before the cancer does, right? Depending on what kind of cancer it is, if it's terminal. Or if we're dealing with a frail elderly person, we're probably not going to be super strict on trying to get their blood sugar down because they're at high risk for falls. And if you have hypoglycemia, you can get dizzy, you can fall. The fall is more dangerous for them at that age than a little bit of hyperglycemia. Now, if you're like my dad and you were diagnosed at the age of 40, then we need to be strict with you because we're still expecting that you will live longer and you're young enough, you're strong enough, you can understand, you can move around a little better, so we might be a little stricter for you. Okay. Our goal as well is not just the numbers, but you guys know that I'm big on not just numbers. It's not just the numbers, but it's also preventing that microvascular complication. ASCVD is the leading cause of morbidity and mortality in patients with diabetes. How many people got that question right on my booklet? Okay. So cardiovascular disease, heart disease, is the leading cause of death in diabetes. So having diabetes, because like I said, hyperglycemia over a long period of time is when you start getting those macrovascular complications. The one that actually gets you fastest, for lack of a better term, is the heart disease, okay? And that's why if you dial back to, cardiovascular pharmacotherapy, that's why I told you guys that if a patient has diabetes and they're at least 40, they need to be on a statin, right? You guys remember that? And that's because of this, that's because of the morbidity and mortality that's associated with diabetes and ASCVD. If you do have a patient that is struggling to get their blood glucose under control, we generally work on their fasting blood glucose first. So that's the first blood glucose that they check when they wake up in the morning, that's the fasting. Once we get that under control, then we work on getting their prandial glucose under control. So that one kind of tells us like how your body is working in general, because the fasting does, because it's not really working on a particular meal, it's working on your blood glucose as a whole, right? But with the prandial levels, we can control that with what you're eating, how much you're eating, and then we can also control that sort of with pharmacotherapy, right? But whenever we're struggling to get a patient under control, we focus first on the fasting, and then we work on the prandial glucose after that. I mentioned that the A1C goal was less than 7. So before A1C became super common or super available, we used to just use fasting plasma glucose. And if I were trying to, I don't want to use the word cheat, but cheat. I know I have a doctor's appointment the next morning. I might just be real good today, right? I may, just not have anything for dinner, just, try to have a salad for lunch, just that coffee for breakfast, and then go in the morning and check, and the doctor might be like, okay, all right, I see you're making improvements. It's still not going to be perfect because there's still residual from whatever, but the fasting plasma glucose just looks at a moment in time, versus an A1C that looks at 3 months worth. So you can't cheat on that. Like that, whatever it tells you is what it tells you. So we love the A1C. It's a lot more consistent, and it tells us the truth. You can't cheat on it. So keep in mind, A1C shows about 3 months worth of blood glucose. So we don't do it any more often than every 3 months because it's not going to give us any more information. So it's done quarterly in patients who we're still trying to establish or they're not at their goal. But if patients are at goal, then they can come back every 6 months, and we do it twice a year. So if a patient has diabetes, we are seeing them at least twice a year. Point of care testing is preferred. So what that means, you guys know what point of care means? A point of care test is something where you come into the doctor's office, we check it, it results right away, and we act on it right away. So that's called point of care testing. We like it for anticoagulation, like if a patient is on warfarin, we want them to be able to come in, check their INR, and then give them directions right away. And the reason we prefer that is we can lose them. And it's better to talk to them about what's actively happening versus what happened when they last got their blood work. So we do prefer point of care testing for that reason. So a patient comes in and we say, your fasting plasma glucose is this today, your A1C is this today, okay? Because that helps the patient. I think it must be like a door.
It's a door. Sorry.
Oh, that's somebody going out there.
Oh, and then the wind's just. Alright, so type 1 diabetes, we monitor patients with relatives that have type 1 diabetes. That's how we screen them. Generally, most patients who present with type 1 diabetes has a first-degree relative with type 1 diabetes. So we almost know who to look for type 1 diabetes in, okay? It can happen for the first time for someone, but for the most part, they usually have a first-degree relative that already has type 1 diabetes. For type 2 diabetes, we screen everybody from the age of 45. If it's normal, we repeat the screen every 3 years. Now, if a patient is obese, overweight, and has at least one additional risk factor, then we do screen every year. We don't wait till every 3 years. The BMI of 25 is not very difficult to reach. Like most of us kind of live around that 25. So most people will need to be screened at least once a year. Gestational diabetes, we said at the first prenatal visit and at between weeks 24 to 28. Alright, so I am not scheduled to teach you the medication piece, but I needed to go over the medication piece to be able to talk to you about the guidelines. So we'll just quickly refresh our memories on the medication piece, and then I'll talk to you about the guidelines tomorrow, okay? Metformin, tell me what you remember about metformin without looking. That's what we wanna use, whenever we can, we wanna use metformin, because why?
It has the highest efficacy.
It's super efficacious, super affordable, it doesn't cause hypoglycemia,
And it lowers the A1C.
it can, it's not,
Weight loss.
so it's weight neutral, it's weight neutral.
It has the biggest one that's not.
It has the potential for weight loss, but as far as oral meds are concerned, it is the most efficacious. It decreases A1C by 1 to 2%. And you can be on metformin forever, pretty much, right? Because of its mechanism of action, it works to reduce hepatic glucose production, it increases insulin sensitivity, and it reduces the intestinal absorption of glucose. So it works for a long time versus something like a sulfonylurea that works on secreting insulin. If you don't have any beta cells left, eventually a sulfonylurea is not going to be able to work as well because it can't secrete any insulin from anywhere, right? But metformin, you can sort of be on it pretty much forever, okay? Your SGLT2 inhibitors, canagliflozin, dapagliflozin, empagliflozin, or tugliflozin, these,
Decrease,
think of the flow of urine. Actually flows in, flows, it flows, okay. Alright, so it works by inhibiting your reabsorption of glucose from kidneys. So you end up excreting more glucose than you normally would. So it says, it goes to the kidneys and says, don't take that glucose, we don't want it. So it ends up going out in the urine. So there's more glucose in the urine, but there's less glucose in your body. So, you know, all the side effects are related to that as well, because now you have sugar in places sugar shouldn't be. Okay, so we end up having more UTIs and fungal infections in areas where we don't want those to happen. But there are calories that are lost by not reabsorbing that glucose, so patients lose weight. It doesn't cause hypoglycemia because it's not messing with your, the food that you just ate. It's, you know, sort of all the way down before it starts messing with you. And because I think of, well, I don't know if it's because of it, but there is a benefit, which I still struggle with why, but there is a benefit to diabetic kidney disease. So it actually reduces the incidence of diabetic kidney disease, and I thought it would struggle there. But apparently, I guess if your kidneys are not keeping as much glucose, they do better. So there is a benefit with this drug class for ASCVD. There's a benefit in patients with heart failure, and there is a benefit for diabetic kidney disease. So this is kind of, it's not a new drug class per se, it's probably been around at least 7-8 years, but they keep getting data to show all the different benefits it has. So it continues to sort of be a favorite child, but it is still expensive, but it is oral once a day, so it's pretty easy to take. Oh, I still do expect you guys to know the brand names for all of these. No. This is just because I'm calling it a refresher, and somebody else is gonna come in and actually do the medications with you, so that's why I didn't put all the information on there, but you're still required, you know that. I saw your hand almost going up, I was like, let me just answer the question right now. GLP-1 receptor agonists, exenatide, liraglutide, semaglutide, dulaglutide, lixacenatide. Alright, this one is not as easy to just put together. I mean, it has the tides, I guess, but I would have preferred if they were all blue tides, but it's fine. So the GLP-1 receptor agonists, they increase glucose secretion, decrease glucagon secretion. They also work on the GI tracts by slowing gastric emptying, help you feel full, and works mostly on postprandial glucose. These ones are definitely probably the ones getting all the attention right now because semaglutide, which is, what's the brand name? Ozempic. Because we all know the song, I won't sing it because Dr. Papers is here, but we all know the Ozempic song. Ozempic now has an oral version called
Rebellious?
Ribelsis. Yes, did I teach it? Because I wasn't sure if it had come out before I taught you guys. Okay, because it's pretty new. But because it's oral, it does have more GI side effects associated with it than the injectable ones. Still just as expensive. The injectable ones, advantage or disadvantage depending on how you feel, can be as infrequent as once a week, but as frequent as twice a day if it's Byetta. So I don't love this drug class because it just varies so much. Like it has oral, it has injectable, it has Byetta twice a day, liraglutide once a day, the other ones once a week. Then liraglutide has Saxenda, which is the weight loss version, and semaglutide has Wegovy, which is the weight loss version. So there's a lot happening with this drug class. But that also means there are lots of questions that can come from this drug class. So just get to know it, get to love it. What I can do for you is I'll post the P1 lecture, just in case you've lost it, or maybe I updated it. I'll post the P1 lecture for you as well, so that you'll see the brand names for all of this stuff, okay?
Thank you.
DPP-4 inhibitors, they work very similarly to the GLP-1 receptor agonists. So a lot of interventions that you will end up making as pharmacists is trying to prevent the prescribing of both of these together. So they both work on that GLP-1 receptor mechanism. So if a patient is already on a SGLT2, there's not much benefit from adding a GLP-1. Okay, so you will end up having to make that intervention quite a bit. I didn't include the DPP-4s, so they tell me what they are. What is it? Januvia, you said. You said Trajecta. There's one more. Alogliptin, which is Nesina. Onglyza. What's Onglyza? Saxagliptin. So sitagliptin, saxagliptin, alogliptin, and did I say 4? Okay. I don't remember. Okay, I do remember. I know everything all the time. Alright, maybe taking with or without food, still expensive, oral once a day. And then TZDs. TZD, I should say, because really nobody uses Avandia anymore. It's Actos pioglitazone. And it works by increasing the sensitivity of muscle, fat, liver to insulin. So they're considered insulin sensitizers. It's oral. It's not associated with hypoglycemia, but it is associated with weight gain. It is the only one that you have to avoid in heart failure because of fluid retention. It's associated with edema, fluid retention, but it is affordable because it's now generic, okay? So we avoid it in heart failure. That's the only one that you have to avoid with heart failure. And then last but not least, sulfonylureas, glipizide, glimepiride, glyburide. These are insulin secretagogues, so they work to help release insulin from the beta cells. So they can be super effective at the beginning when you still have beta cells, but the less beta cells you have, the less effective it becomes. Okay? Oral, but it is associated with hypoglycemia, it is associated with weight gain, but it's very inexpensive. So for people who are newly diagnosed with diabetes, it's a really good option. Okay? you do need to know where each of these insulins fall. Which one's rapid acting, short acting, intermediate long acting, ultra long acting. Ultra long acting is still dosed once a day because nobody can dose anything every 36 hours. So we really don't care that it's ultra long acting, it's still dosed once a day. And then the different combination products. Okay. Questions? There are more anti-diabetic medications than what I just went over. These are just the ones in the guidelines, right? That's the only reason, that's all I went over. So hopefully we'll get a full picture of everything else, but these are the only ones that are in the guidelines, so these are the only ones that we really recommend. But you will get a more comprehensive picture of everything. All right?
When you
Questions?
say combos, do you mean just those four, or you mean like all these? Yeah, I just want to be,
So these are insulin combos.
so just the insulin combos?
Okay, so Dr. Hebers, I don't know. They're gonna get this from somebody else, right? Okay.
That's the.
Oh, I think in public.
From Dr.
No, but in pharmacotherapy.
Oh, yes, yes, they are. Yeah.
So the only reason I'm going over this is because you have to know this before I can explain the guidelines, but you will get much more detail. But you do need to continue to know those combination
Drug
products.
questions are guidelines, treatment, drugs for someone else.
Yes. So this was just a quick refresher so that when I talk about the guidelines, it will make sense to you, but somebody else is going to do a deep dive into the medications.
Okay.
Yes.
Next Monday.
Intermediate is without meal. Short acting is after you place your order. Rapid acting is the waitress has the meal. Right there. Alright, see you tomorrow. I will let Daniel know depending on the weather, whether we're in person or not. Let me know that I love seeing your faces.